because there are a lot of robotic-related talks. So I invite Dr. Anil Arora for robotic-assisted valgus knee in CT-based fully automated system.
Can we? Thank you, Dr. Prasad and team, for inviting me here. A bit difficult topic, a valgus knee and robotic planning. So, yeah. So here we have a lady about 60 years of age with a valgus knee on the right side and about 15 to 20 degrees. Preoperative gait. And range of movement. She had correctable last 5 degrees of flexion deformity. Now, how do we plan this case? We have used Cubis robot system, CT based. I'll show our planning.
I think this is not.
Do we have a pointer?
There is not connection there.
Connection is not there. No, that's okay, but it's not showing up here. यहाँ दिखा नहीं रहा है, वीडियो नहीं दिखा रहा है, प्ले हो रहा है, वीडियो प्ले नहीं हो रहा है मैं, डिस्प्ले अटक गया है देखो, वीडियो रनिंग है,
आपका पेन ड्राइव में कहाँ पर है सर वो
वीडियो है ना, फोल्डर में सो बंद कर देता हूँ, ये
अच्छा चलाइए
इस फोल्डर में है,
हाँ चलाइए सर इसे चला दीजिए,
उसको बंद कर देंगे, लेट अस सी, उसको बंद करने से कुछ होगा, we can start from the very beginning. Okay? This is how we planned this case. This is CT-based system. Pointer आपने पास दिया. Femoral head center. The condylar center. The medial epicondyle. In this case, we took surgical trans-epicondylar access. We took sulcus behind the medial epicondyle. And various bony points, medial distal condyle, lateral distal condyle. There was no notching. The size seems to be adequate in AP as well as medial lateral dimension. This was size C. So still we have some margin. We can still, if required, posteriorize the component. We kept it 1 degree external rotation to surgical trans-epicondylar axis. Registration points, medial, lateral, proximal, anterior medial, anterior lateral, posterior medial, and posterior lateral. Tibia center. We took 3 degree posterior slope in this case. Center of ankle, center of talus we took, center of ankle. These are various points you have to pick up after you do segmentation of your CT image. This is done in preoperative, this is preoperative planning. We register the morphology of femur intraoperatively also with the same registration process. Various points taken. 3 degree posterior slope. We slightly anteriorize the tibial tray for safety. This was size 1, the smallest possible size with these company implant. 0 varus valgus and various recession points. The lateral, the anterior, the tuberosity, the proximal medial, proximal lateral on tibia as well. We'll verify these points intraoperatively. So taking summary now, we had planned for mechanical access. So I'll show you the summary of the planning we did in a slide. We had planned for mechanical access. Rohan, there is some time. We were cutting distal 4 on the lateral side. Posterior medial was 9.6. The implant is 8.2. Posterior lateral was 8.8. And we were 1 degree external rotation to surgical transapicondylar axis with one size tibial tray with proximal medial cut of 7.1. This is intraoperative. After soft tissue tensioning, it was tight in flexion. If you see the gap, the predictive gap is 8 millimeter on the lateral side, 13 on the medial side, and then we made various arrangements. We posteriorized our femoral component by 1 millimeter, brought it to neutral, parallel to surgical transapicondylar axis. We were 1 degree in external rotation, and we flexed 2 millimeter, and we distalized by 3 millimeter. We were able to achieve in flexion almost equal gaps. And in extension, gap was 10, so we distalized further by 1 millimeter. So we got almost 9 on all the sides. And by doing this adjustment, this is the postoperative X-ray. We were able to achieve desired mechanical access. One can see patella centrally, because the patient was obese, we used a stem. And if you see patella tracking, it was extremely good. We took our component parallel to, so without much soft tissue releases, we were able to achieve a balance in the valgus knee by playing around on the femoral component. So that's the post-op. Clinical picture. I don't think videos will work. This was done recently with good range of movement. So thank you very much. This is what I wanted to show, the planning in the valgus knee.
You had to do some soft tissue release in this case?
No.
No.
Fortunately, it was severe deformity, but largely correctable.
So, Dr. Arora, what was your pre-op valgus?
Yeah.
Pre-op valgus.
How much valgus?
Valgus, about between 15 and 20 degrees.
Yeah. So, I just want to ask the panel everywhere here. So, if you have Rajkumar, if you have 15 degree valgus, what should we be aiming at the end result?
15 degrees
In the pre-op valgus, how much should we be aiming? Should we aim to bring it to full correction, neutral, or should we leave it slight valgus? How much should we be doing it?
It's a little different when compared to varus and valgus. If it is a varus, definitely you cannot take it to valgus or neutral. In fact, it is better to keep it 1 or 2 degrees of varus residual. Even 3 degrees of varus doesn't matter. But that varus has to be the clinical one and not the tray. You cannot put the tray. But in a valgus, the situation is little different, because in valgus, it is the stability which matters. So if you trying to bring the tibial into neutral, and if the stability is good, definitely it is okay. But you need not put it intentionally in little valgus. So in a valgus, definitely I will base on the stability. There is no much of mediolateral instability, that I will accept it. So even if it comes to neutral, I will accept it.
So my question was, if let's say in 5 degree valgus you have got good stability, should you still try to aim and come to neutral or not?
5 degrees of valgus, it is very unlikely if you have a 5 degrees of valgus, residual valgus, but still there is some stability. That means there is something where it is not okay. So if your stability you are able to achieve, you will be having either 1 degree or 2 degrees of valgus, then or maximum 3 degrees of valgus. But 5 degrees of residual valgus and stability, something is not okay.
So Jitin, welcome. What do you feel about that? And I would suggest everybody who's a delegate here, please look up to your Google, type this answer and try and find out the answer for this. In valgus knees, what should you aim as a final result?
Why Google? We will try to discuss
No.
and find out.
Let the delegates also do some homework. So Jitin, for you.
So, two things. One, I do not only knee replacement, I do soft tissue surgery. So I understand what is the relevance of MCL. Even if there is a MCL rupture, for example, and the knee is in 1 or 2 degree of valgus, that knee is gone. So you cannot leave a knee with doubtful medial collateral ligament in even 1 degree of valgus. It will stretch out. And a valgus like this lady must be having a MCL which is not really functional. On the table it may appear whatever, but when the 80 kg or 70 kg weight goes on that, over a period of next 1-2 years, it will open up on medial side. So I would always prefer where the MCL is actually stretched, I will prefer a 1 or 2 degree of varus alignment overall, not even neutral. It's not on the question of on the table what you feel. That's only 5-10 kg. But 70 kg going on for next 10-15 years will stretch out the MCL, and that's a disaster for a knee replacement.
So you leave your knee in varus, Dr. Maheshwari, 0 degree or varus?
1 degree varus, not even neutral.
So
if my MCL is doubtful, 1 degree varus.
So it was quite stable, and if you note, we have used varus valgus constraint.
So on the table, stability is not important. What happens when she walks? What happens when she walks for 5 years? That's the question. She'll be fine for 1 year maybe with your constraints. Let me tell you, if there is a valgus opening, even hinge does not stay. After a while, even hinge opens up or something happens or the fracture happens. So you cannot play with a MCL which is little doubtful. You cannot give an alignment not friendly to your MCL. So all alignments have to be friendly to your MCL.
This is you have seen, or this is what you think?
This is my understanding from my overall surgery, knee surgery, not only joint replacement, even reconstruction.
So have you seen such cases?
I have seen such cases, plenty of in the literature. Plenty in the literature.
I think to stop this argument. So I have given you all the delegates a job to do. Please type. And if you're still confused, type J.L. Brad's paper. Okay? So and then come back. When I come for the panel discussion, I want that answer from you guys.
So great case, Dr. Arora. Yeah.
So can we take home this message that if it is a valgus knee, it is must to put in 1 degree of varus at least? Not neutral?
No. Neutral.
Neutral is
because
preferred,
Dr. Maheshwari is not happy with neutral.
So the delegates will give us this answer. Dr. Arora, the delegates will give this answer. Please do that.
So next,
Neutral stable knee.
I invite Dr. Hemant Sharma for the next talk, the functional alignment with MECO.
Thank you, sir. Thank you for having me, and I thank organizers for the lovely arrangement, and apologies for being so casually dressed because straight away I came here and didn't get time to change. So I'll be talking about my experience with the robotic system, and I use a MECO system, although I've used a bit of a QVIS and a navigation system from Johnson, Brain Lab, Escolab navigation system, and Striker precision navigation system, but not as much as Dr. Vaidya has used, so I could pick up a lot of good things. So since the robotic surgery I started, I'm doing only functional alignment. As Dr. Rajkumar said, there are different names. I feel that for mechanical alignment, pardon me if someone is hurt, that why you're using a robotic system for a mechanical alignment, because you can easily get many cheaper ways to get a mechanical alignment even without a robotic system. So patients are dissatisfied, we all know. So the whole aim is to find out why patients are dissatisfied. They have instability, malalignment, PF joint problems, stiffness. Some of the factors are modifiable and some we can't change. So mechanical alignment we all know. I don't need to tell you, we are cutting everything at right angles and our HKA axis is 0. And femur is rotated to 3 degrees of external rotation because we want to compensate for the varus which we have not given. And patient satisfaction is 80 to 82%, and only 33 to 54% of people will have ongoing issues. A compensatory external rotation in the femur is for loss of normal 3 degrees of varus in the joint line. So we know that 15.4% of the normal knees and only 14.6% of the arthritic knees have a neutral alignment. So which means in most of the cases we are doing, we are giving them a mechanical alignment which is probably not what they are used to. So 85% of patients, a mechanically neutral joint replacement is not restoring the joint line obliquity. So anatomical alignment, I'll skip this. There's a talk on kinematic alignment. So in kinematic alignment, you are cutting the equal amounts. I think we have a gentleman who's going to be giving a talk, so I will quickly skip. You are cutting and taking into account the pre-arthritic damage and not doing much to the soft tissue envelope. So pitfalls. So let's go. So this is just a revision to show what is a hip knee angle axis, what is LDFA. Now with the newer software, we are able to calculate preoperatively every patient's LDFA and MPTA. That software has not yet come, but it will be soon there. I have used that in the R&D division. So why not give them a pre-arthritic alignment? Why not give them a constitutional alignment? Why not give them a joint obliquity to which they are used to? Like Dr. Maheshwari said that I would leave them in varus, probably because they are used to walking like that. So for knee in neutral alignment, the HKA angle is approximately 1 to 1.5 degrees of varus. Whereas in healthy individuals, it can vary between valgus to 3.2 degrees of varus. So functional alignment uses a robot. So everyone has praised their robots. So let me tell you, the worst thing about this system is that one day I'm going to be deaf because the sound production is so much that at 80 decibels we will lose hearing, and at 60 decibels this machine is working. So now I literally, when it is a cutting time, I don't cut and let someone else cut the bone, and they take chances. The other thing is all the robots except Valis are industrial robots. So I've not used Valis, but if I'm correct, Valis is not an industrial robot, correct? The rest all are industrial robots. So let's give the patient the native alignment. Let's try to maintain the joint line obliquity. We used to say knee replacement is a soft tissue surgery, but now we are not at all doing anything to the soft tissues. Everyone doesn't want to touch the soft tissues. Previously, we were balancing everything to the soft tissues. We want to match the implant as perfect as possible to the patient's anatomy so that patellofemoral problems are not there, and we want to balance the knee in flexion and extension. So I feel it is reproducible, yes, planning is mine, and I restore all my knees the joint line obliquity of 3 degrees. So I have to write on the X-ray functional alignment because some of the X-rays have gone out and someone has said the tibial component is placed in a wrong position. So now I write it on every X-ray, it's a functional alignment. Now we do a CT planning. I'll skip this, center of hip, ankle, knee, map it. Then you have to again, confirm what you have done. And if you are not registered properly, the robot will not let you proceed. So unlike some of the systems where your hand is doing the mapping, so I feel the accuracy is better in the image guided system. But at the same time, we are exposing them to the radiations. I'm sure US FDA must have done some studies that these radiations are not as harmful as we think, but I'm not sure about it. Now that's the preoperative alignment. So this is just to show you that I've got a gap of 21 on one side and 14 on the other side. With the implant I used, I want a gap of 18, 19 in both flexion and extension. So now you know that you have a gap of 14. I've done nothing. Then I have stretched the ligaments laterally and medially. My gaps have been recorded to 26 and 20. Now that's a very big gap. I have to reduce these numbers from 26 and 20 to as close to 18, 19, depending on how much thicker poly I want to put. That's where comes the role of putting a pivot point at one side and rotating the femurs, tibias. But there is a boundary. I can't do put a 7 degrees of varus, the robot will warn you, you're not allowed to do that. And it is based on the papers we have in the literature from Australia and other places. So if you see an extension with my ligament stretched, my gap is 26 and 20. Now I flex the knee, and in flexion, my gap is also 26-20 after stretching it. And after that, so now, so here comes the balancing, and after this, actually, the hardly any role of a surgeon. Robot can do the cutting for you. So how I'm going to get these gaps to less numbers? I can distalize the femur, I can proximalize the tibia, I can external rotate my femur, I can give 3 degrees of varus to the tibia, I can give 1 degree of varus to the femur. But combined flexion in this system, combined flexion of the femur and tibia should not be more than 8. Because this is a single axis radius system, maybe it's not applicable to the other knee systems. So once we have matched the gaps, if you see the image on the left side, we have 18 and 18 and 18 and 18, and then you just leave the things to robot, it will cut it, you put an implant. So it does make the life easier. I think the learning curve for the younger generation, they will find it much easier, but they should know how to do the other knees. So now it's up to you. You can do a mechanical alignment, you can do a functional, you can do kinematic, you can do reverse kinematics in this system. So most of the knees we get in India are so bad that they are not suitable for kinematic alignment because there's a lot of varus deformity. So as I said, you can have a flexion and extension mismatch of approximately 1 millimeter, and flexion and medial and lateral gap mismatch of 1 millimeter should be there. In CR knees, the flexion should be slightly looser, and PS knees, it should be equal. So we, in coronal alignment, we match the resection to the MPTA, so which is medial proximal tibial angle. So no tibial overhang, match the slope to the native slope of the patient, anatomical fit. In femur, we are matching it to the lateral distal femur angle and modify it according to the soft tissue laxity. And rotations, depending upon whether you're using a posterior condylar axis or transapicondylar axis, there are some numbers. So there is no overhang, no overstuffing, and we restore the trochlea and posterior condylar offset of the femur. That's very important. Posterior condylar offset. So my talk was about early results. I would definitely say that patients have left the stick pretty soon. They are walking better initially, like at 7 days they are coming with minimal support, and this lady is 10 days bilateral, so she was trying to show me she doesn't need a stick, but I don't think that's a measure of a success of surgery. Whereas when I see them at 3 months, all of them are saying the same thing, what the non-robotic knees said. I've got some stiffness, akdan, jakdan, hararat, some pain in the knee. So this is a true statement I'm giving you. But yes, in early days, I can make a video and show them in 7 days they're without the stick. Their stance phase is much better compared to the robotic knees. So the way they are doing a heel strike is much better. The soft tissue envelope is less released, so I feel the less of inflammatory tissues are released. And for pain controls, we are all using blocks and stuff, so I don't know, my pain control is due to the adductor canal blocks or the medicines I'm giving. But initial improvement is there. So everyone has said the robot is showing good results. I do believe that, I want to believe that, but there are many papers to show that no difference. So yes, it is useful technology. And moreover, I'm very glad, sir, you showed a very complex case of valgus knee and varus knee. I feel that if it is a very complex case, I would probably think of non-robotic than a robotic, because robotic has its restrictions, right? So it will say that beyond this, the gap is not opening. So you have to do, so there is a different pathway to do these cases with the robot. You cut the tibia first, distal femur first. But in my system, I just, once I've fed the information in the computer, then all the cuts are at the same time. Not like I cut the tibia first and then I do a gap balancing, because everything is done beforehand. So But the other question I ask everyone is, if I give a free robot to every one of you, will you use it or not? So people who are non-robotic lovers also say, yes, we will use it. So that means somewhere or the other, they know it is better than the others. So major difference between the functional alignment to the previous philosophy is that modification of the alignment is based on the anatomy of the patient and soft tissue laxities. So both of them are taken. Knee screws have improved. We are balancing the knee in 0 and 90 degrees, unless your system where you are balancing in a lot of range of motion of flexion. So this makes sense with the striker single axis radius. But I don't think balancing purely in 0 degree and 90 degree will be equal to a good balance in all the positions, because your implant is multi-radius, it's a changing radius. And this implant is single radius, so I don't need to balance in 120, 140 and stuff like that. Thank you.
Okay, thank you. One question, please, only.
Yeah, Hemant, you are a very experienced surgeon. You must have done thousands of knees.
No, now robotic is 300.
No, not with robotics, with normal.
Yeah.
So with this 300 robotics or whatever, do you think it has made you even a better surgeon than you were before?
Okay. It cannot make a third-rate surgeon into a top-rate surgeon, right? There are times when I have done a robotic alignment and I still feel I'm tight laterally, I'm tight medially, and then I just use my brain. I have to do some releases. I have done pike resting of PCL, sometimes of popliteus, which I've never done in my life before in the non-robotic. I was doing a varus knee, and in 3 cases, I did a varus knee, and my lateral side was very tight. So I was surprised that, is it some new classification I'm trying to see, that why in a varus knee my lateral side is tight? After trial reduction, my poly was not going laterally. So when I did a needling of the popliteus, it just went in. So it has saved my time. I've become, when I do a non-robotic, I know what are the parameters, how much, like little bit, it has definitely made me better. And I can let my junior do the surgery because I know he cannot do a fault because everything is visible. But the saw we are using, I'm sure we are going to have carpal tunnel syndromes because that's a lot of vibration and a lot of noise pollution. I don't think anesthetists can listen to you or you can talk to them. So they should provide AirPods with all the robotic systems to all the surgeons.
Thank you, Dr. Hemant. We'll move to the next speaker, Dr. Nabil. He'll be talking on robotic kinematic alignment.